Hello everyone. My name's Andrew Roberts. I'm a clinical haematologist at Royal Melbourne Hospital and paediatric. Also do research at the WEHI, and I'm the Metcalf Chair of Leukemia Research at the University of Melbourne. It's my pleasure to host today's session. In beginning, I'd like to begin by acknowledging the traditional owners on the land on which we meet today, wherever you are online. For me in Parkville, this is the Wurundjeri people of the Kulin Nation, and I pay my respects to elders past, present and future. And I'd like to extend that to all Indigenous Australians present with us today online. Before we go, I introduce the speaker. I want to just orientate you to a couple of housekeeping notes. Today's event's being recorded and will be available on the BCCC Alliance Open Learning page, where you can also view previous webinars, and you can see the URL for that down below. If you have any questions for today's presenters, you can do this via the Zoom Q&A function, and the cheat sheet is in front of you there. I really hope you will submit your questions. We're in for a treat today in terms of a lecture, so I think there'll be a lot to explore further. If you put them in the chat, we'll aim to answer all your questions at the end of the session, not during the presentation. With that, I'd like to move to introduce Professor Karin Thursky as today's speaker. Karin will be talking about the clinical pathways for management of infections in cancer. I think everyone needs to know that Professor Thursky is a star. She's a star in many different ways. As an experienced infectious disease physician, she's also a leader in implementation science. That's reflected in her role as Associate Director of Health Services Research and Implementation Science at paediatric. That began in 2020. And she's helped establish a new Department of Health Services Research since then. She has other key appointments, including Deputy Head of Infectious Diseases and Implementation Stream at NHMRC Centre for Infections in Cancer on campus. She has a leading role at the Doherty Institute in terms of antibiotic stewardship, and also pioneered the implementation of controls on antimicrobials at the Royal Melbourne Hospital. I'll get out of the way and let you get on with the Professor Thursky. Thank you.
Thanks, Andrew, for that very kind introduction. Like Andrew, I do cross across all the organisations in this precinct, which makes life interesting but a lot of fun, and obviously have had the great pleasure to collaborate with Andrew and his team over many years. So what I wanted to do today was really to, I guess, talk about how we prevent and manage infections in cancer. But before that, I wanted to remind everyone that this week is World Antimicrobial Awareness Week. It runs from the 18th of November to the 24th of November every year. Antimicrobial resistance is actually a naturally occurring phenomenon. It is one of the global challenges of the world, and I think we need to be reminded that the reason we can undertake cancer care, cancer surgery, and bring in new technology is because we can actually prevent and manage the infections. So underpinning all the work that we do with infections in our cancer patients, it's actually primarily about patient safety and judicious use. And so you'll hear that all the way through my talk about how we can use antimicrobials. We need to use them, but we need to use them appropriately. I guess the second issue is, what is a clinical pathway? Actually, we talk about clinical pathways, but what is it and how do we use them? And clinical pathways are different from guidelines. They require a structured approach to the plan of care. It needs to facilitate the translation of guidelines into the local practices. So very few clinical pathways are actually plug and play in your own organisation. They need the time to be adapted for the local epidemiology, patient population, acuity of illness. It needs to include some detailed steps with some time frames, and it aims to standardise the care. And I always talk about the fact that clinical pathways need to support that junior HMO that comes onto the ward in the middle of the night, or a nurse that's come from a bank and has to deal with these complex patients. And so clinical pathways in cancer are obviously very common. All of you will know that clinical pathways in the management of myocardial infarctions are very common. And in fact, the introduction of clinical pathways in trauma, GI bleeding, stroke, and ischemic heart disease have dramatically improved the mortality rate. And so they do, and like in some of the areas that I'm talking about, do actually improve patient outcome. The National Cancer Strategy also focuses on the concept of care pathways, so-called optimal care pathways. It still is surprising, however, though, if you look at the National Cancer Strategy, very few, this is the only optimal care pathway that actually talks about infection. It's largely silent in the National Strategy, and it is silent in optimal care pathways for pretty much all the other cancers. It's in this one because obviously some of our team have been involved in it. But to point out some key areas, it does talk about prevention and management. It does talk about screening for infections at high risk of reactivation. It does ask you to consider the epidemiological risk. It talks about the sort of serology that these high risk patients with leukemia require, and that it actually specifically says you need to have specific guidelines and pathways that talk about appropriate recommendations, and it suggests that there should be a multidisciplinary team. And this is definitely something that we've promoted for a long time. And at least in the Parkville precinct, we've worked very hard to create an embedded model of care where the infectious diseases team are part of routine care, and so facilitating the appropriate management. We also need to recognise that our cancer specialists often have to make rapid decisions, and they may have to make decisions about how to treat infections before any diagnostics are available. And so we have this challenge of, well, how do we make sure that the patients are appropriately managed? Often sepsis is a prime example where it's very time dependent. Everyone is terrified of missing or under-treating sepsis because patients do die, and mortality rates of up to 25% with severe sepsis. Balanced against this issue of judicious use. So how do we make sure that we use our antimicrobials appropriately to avoid over-treatment or inappropriate treatment? There's a lot of emerging evidence around gut health, dysbiosis, microbiomes on efficacy of cancer care, and our patients are starting to ask about it, so they want to know, why we've been given antibiotics. And then there's that future risk of AMR, and which is a little bit difficult and hard to handle, because in reality in Australia we're in a reasonably good position with antimicrobial resistance, although we do have some things like VRE, which are very high rates. So clinical pathways can deal with this. They can provide the structure as well as providing the guidance. So let's turn to neutropenic fever. This is the most common infective complications in patients, and it's fair to say that with the newer agents, checkpoint inhibitors and the like, we're starting to see less traditional chemotherapy and perhaps lower rates, but nevertheless we still see neutropenic fever in solid tumour patients at a lowish percentage, but definitely in haematology and bone marrow transplants it's a very, very common problem. And in half of those patients will develop sepsis. The other half, there's very good evidence that they can be managed at home. At the same time, we need to keep on top of all the new agents coming, new patients at risk, and it's really a moving feast. I think I've said this to Andrew over the years, every month there's a new trial, new drug, and it's we spend a lot of time trying to understand what is the suspected infection complications in these new treatments. We did publish and put together a multidisciplinary consensus set of guidelines for neutropenic fever a long time ago now, and in fact we're just pulling ourselves together for an update. So in Australia, we've been very fortunate that we have had these consensus guidelines around the role of risk stratification around empiric antimicrobial therapy. We've looked at hospital-based empiric therapy, and we've also put forward guidelines to manage ambulatory care. And then Australia is in a unique position because we don't have, I guess, the degree of resistance that we see in Europe and America, and we do not promote a lot of antimicrobial prophylaxis, which is perhaps a routine standard of care in the US. Monica Slavin and I have written a number of editorials around this, around the importance of avoiding widespread use of fluoroquinolones, which are definitely associated with resistance. But these are issues that are continually need to be updated. So what do we do around this? How do we go about implementing this new framework of low-risk neutropenia? And this is the work in adults, but then I'll move on to some of the stuff that we've been doing with paediatrics, which is really amazing and exciting. So first things first, we sent out a survey. It was endorsed by all the key bodies, and we provided some case studies to both haematology and oncologists and RD physicians. We presented these case studies deliberately presenting those patients we considered to be high risk, that would absolutely need to be admitted and often given double antimicrobials, versus those that are clearly low risk that could be managed at home on oral antibiotics. And it was very interesting because in both cases, 1/3 of the clinicians picked or chose that the patient was high risk even though they were low risk, and that there appeared to be a knowledge gap around the existing scoring system, or the scoring tool called the MAS score, which had already been well validated in identifying low risk patients. And so then we asked some further questions in the survey, and they said, well, if there was a risk score, we'd be very happy to use it. And actually, we'd quite like to manage our patients at home as long as their risk was managed so that the patients could be readmitted. So we then went on to build this consensus guideline for the using the score to guide the management. At the same time, we said, well, what sort of impact is it likely to have? And we looked at the economic burden of neutropenic fever using Victorian admitteds episodes data sets, and we could see that, by introducing a program, we could model cost savings, and that they were very likely to be cost effective. After that, we did a short pilot at the Western Hospital. They were wonderful early adopters, and that's always important when you're implementing something, that you want a site to put their hand up and say, yes, we'll do it. And we showed that it was very feasible and very successful, and in fact 90% of these patients appropriately switched within 24 hours and went home. So that was a pilot work. And so the current program is in our ambulatory pathways. If we have a neutropenic febrile patient and they're deemed low risk, they go into our ambulatory program versus those others that come in. And at that point, for the sicker patients, we always need to ask the question, is it sepsis? So we'll deal with sepsis later, but at the moment we're dealing with the low risk patients. So that's our current pathway. This entire strategy, in terms of other opportunities to bring in patients, for example, neutropenic monitoring, patients being given therapy at home, there are many opportunities to scale this program, which is a nurse-led program, into our routine care. And so we've called the program There's No Place Like Home, and it is a nurse-led program. We identify the patients, we transfer them into the hospital and the home service, and this particular program was supported by a grant through Better Care Victoria and was scaled to Monash and the Royal Children's Hospital, and it was actually a failed implementation at the Austin. They didn't recruit anyone, and that's where it's very interesting when you look at work pathways and how programs perform in different hospitals. You do need to accept that in some cases there will be failure. And so this has persisted. In fact, the savings from the program help fund our nurse practitioner, the current nurse practitioner. If you jump onto the National Centre for Infections and Cancer website, we have the full program toolkit, the checklist, the medical record document, the education package, the policies, and observation charts to help you implement it. And if anyone is interested, we're always happy to assist with that implementation program. So if we think about cost predicting these programs in our current environment, particularly during the COVID pandemic, there's definitely been an increased interest in shifting care into an ambulatory setting. And we have found that through our quality of life surveys and other surveys that both the patients, parents and children actually prefer to be at home. And so we know that this is going to be something that will be an emerging issue in building these programs. So we look at neutropenic fever, usually around 1/3, 30 to 40% are deemed low risk to be sent home. And we have looked at that modelling, and we've worked with Michelle Chews, who's one of our embedded health economists at PeediaMac, to look at what would be the impact. This is in the paediatric space at the Royal Children's. It reduced length of stay from 4 to 1.3 days. It was very safe. And there was an average cost benefit of $4,200 per patient. In the paediatric space, of course, the children actually go home to have IV antibiotics because oral antibiotics are problematic for some, often for kids. And in the adult space, again, similar reduction in length of stay, again, safe with cost benefit. And we've looked at the impact of national scaling of this program alone. And that's a very well-defined program. So in adults, it's really only solid tumours and lymphomas where we're looking at how can we expand the risk stratification to include other patient groups as well. This is a recently published study from Gab Heusler and her group who have been developing the low-risk program at the Children's Hospital, where we, for the first time, used a quality of life utility tool to look at what happened during a neutropenic fever episode. And half the kids did not improve in terms of quality of life during the neutropenic fever episode, whereas the other half either were resilient or recovered. And these tend to be female, high-risk malignancies, particularly blood cancers, whereas in the chronic group, you can see that this often happened in male children with solid cancer where there was financial stress and there were relationship difficulties between the parent and child. So when we look at implementation, we're thinking, well, how can we use this data? And I think it's really important examining quality of life when we're implementing, because it helps us to address issues around the supports for patients and particularly families when they're undergoing management of their neutropenic fever, and especially important if they are happier being at home and to support the program. So this is working with Richard Debra-Lorenko from CHEER as well up in New South Wales, and really highlighting the fact that our team is really starting to work with groups across the country. I wanted to spend a couple of minutes talking about clinical prediction rules. They are rife through medicine. We know clinical prediction rules in sepsis, QSOFA, SIRS, NEWS, clinical prediction rules for cancers, all sorts of things, cancer risk. And it's worth thinking about it from an implementation point of view, what it actually means when someone develops a clinical prediction rule. And they're often derived using big data and to be predictive of a particular situation. And the one I'm going to be talking about is risk for paediatrics developing an infection. What is often not done is that there needs to be both a validation as well as an external validation of those rules. So how do they perform? Do they perform in a similar clinical setting? How do they perform in another similar setting, in another completely different population? And does it perform as well? And if it is going to be something that is feasible, then what is the impact of that rule? Will it improve patient outcomes or reduce patient costs? And this is an excellent methodological paper that I would recommend anyone who's utilising clinical prediction rules or thinking about trialling them as to how would you go through it. So we looked at this in paediatrics. There had been already a huge amount of work led through Bob Phillips in the UK, University of Leeds, looking at individual patient data of 5,000, over 5,000 episodes of neutropenic fever, and they came up with a picnic rule. It's a rule of a combination of signs and symptoms that were going to predict infections, microbiologically diagnosed infections in children. And we had the opportunity to externally validate it in Australia, retrospectively first in an Australian data set, and Gab Heusler led this again. And we found that it actually performed very poorly in the Australian population. We then had an NHMRC project grant, the Picnic grant, where we prospectively validated, and we enrolled all the paediatric cancer centres in Australia, and we evaluated not only the Picnic rule but the other clinical decision rules already in use in another 900 patients. And again, the Picnic rule did not perform so well, and in fact there was another rule, a Swiss rule, that performed a little better. And so we recalibrated this rule to create the Oz rule. That then went a further meta-analytic validation in over 1,500 episodes, and that Oz rule is now being scaled through an MRFF nationally, again in all the paediatric cancer hospitals, and it's also been adopted in the UK. And the reason it was rapidly adopted in the UK is because the UK was really struggling with COVID and the paediatric cancer patients, and they wanted to quickly switch to an ambulatory program. So at the moment, we are working to build and implement this program and to look at the safety and quality of life impact. So that's an example of moving through all the steps required to validate and externally validate and test a clinical prediction rule. What about what's next for us? Well, one of the challenges we always have is, well, can we shorten the course of antibiotics for neutropenic fever? Commonly, in particularly high-risk groups, they do tend to go on for some time. Often, even though they're all switched, they do tend to continue until there is neutropenia recovery. But in fact, there have been several randomised controlled trials, including 6 in children, that show that they actually probably do equally well. Only one of those trials is in very high-risk populations, but the evidence is definitely there that we think that we can shorten the course of antimicrobials prior to neutropenic recovery. And in many cases, the patients are actually still in hospital and can be observed. So we are doing a very exciting EPIC-based program. EPIC is our electronic medical record, for those of you outside of the Papua precinct, to look at whether we can safely or effectively stop antimicrobials early. And we are appropriately calling it the ELSA trial. And it's a fully embedded randomised controlled trial. And what that means is all the randomisation, data collection, outcome, all data is collected inside the electronic medical record. And so once the trial is up and running, it's actually a relatively cheap trial to run. But I can tell you behind the scenes, it's been quite a monumental task for the EPIC team to build something of this complexity. I think it was much harder than they thought it would be. But happily, we randomised the first patient on Friday, the start of Antimicrobial Awareness Week. So I'm very keen to bring you up to speed with that one down the track. And part of it is there's a strong qualitative piece around accepting and how people react to prompts and pathways of care through the electronic medical record, as well as physician behaviour around shortening antimicrobial therapy. So stay tuned for that one. I want to switch now to sepsis. And this has consumed a lot of my time over probably a decade now. And I think I became most interested when we did get a WIC-MIX grant to look at neutropenic fever. And I realised that when we looked at what was happening across our cancer hospitals, nearly all the guidelines were really very focused on neutropenic fever. And in fact, less than half our patients with sepsis in cancer actually do have neutropenic fever. And a lot of the guidelines talked about what antibiotics to choose. They didn't really talk about appropriate resuscitation sepsis management. Not to mention that, at least in paediatric, the surgical patients were very underrepresented and and not recognised actually. Cancer patients do present to multiple areas in many hospitals. So they do have ambulatory appointments, direct inpatient admissions, cancer day therapy, radiotherapy, diagnostic imaging, apheresis, and it is not uncommon to have patients who present unwell. In our statewide rollout, we know that 1 in 5 of the patients that came through ED had a cancer diagnosis. And equally, we also know that 1 in 5 of our met calls in hospitals are actually due to sepsis. This is a common problem. This is just to show you literally, we looked at what hospital guidelines said about actually diagnosing or classifying patients with neutropenic fever, whether there was any consensus across the sites, but also whether the guidelines actually mentioned anything about clinical instability. And you can see all the blue where it wasn't actually in the guideline or there was some consensus. So really this was across 6 hospitals, all with very different approaches to A, the recognition of neutropenic fever, and B, how to deal with the neutropenic fever patient that was septic. So we've had the opportunity, we can't do it yet in Australia very easy because we don't have the type of data sets that are available in some parts of the world. So Michelle Chu again and Kim Dalziel, we looked at, we had access to the Ontario ISIS data set, which is a longitudinal linked population data set. It has linkages to registries. It can capture patient care from hospitals, ambulatory care, rehab. And we were able to look at, well, where was the burden of sepsis? What was the timing of burden of sepsis after diagnosis? And what was the cost associated with it? And you can see in the haematology, and we worked with ID physicians and oncologists, Eric Bowe in Canada, confirming that at least for the time period that we were looking at, the quality of care or the type of care was very similar to that was happening in Australia. And you can see that in the haematology population, there was a very significant numbers of patients with sepsis, as well as cost of care, particularly in that very early phase, that first month, but still very significant in the first 12 months. Less so in other solid tumour patients, but certainly in that first month of care. So really, again, highlighting the importance of having pathways in place immediately at the start of treatment. And sepsis, again, this is data from the same program of research. We can see that patients with sepsis really have much lower 5-year survival rates over a 5-year period. So again, a really important area that needs to be absolutely focused on for all patients coming into our system for cancer treatment. However, sepsis is a massive issue because for those of you who have been working in it, there was a new definitions that were released in 2016, but it has become a very amorphous definition. Infection associated with organ dysfunction. There is no gold standard diagnostic criteria, which makes having, for example, choosing clinical prediction rules or developing clinical pathways really very complicated. And we also haven't progressed too far with rapid diagnostics at the moment. We don't have, current point of care tests for sepsis. Of course, we routinely use venous of lactate, but in terms of rapid infection diagnostics, they're still not in place. And at the same time, we do have very time-critical action. So this is a wicked problem that has consumed a lot of our time to build and develop and really required an intensive effort. And really all hospitals, and probably even primary care, needs to think, well, what happens at the moment in our hospital to sepsis patients? What are the gaps in knowledge? What are the gaps in processes and structure? Who needs to be involved in developing the program? And at the same time, how to incorporate those antimicrobial use principles, which I mentioned before, to avoid collateral damage. And this is really what we did with this piece of work many years ago now, but it certainly has led to quite significant change. And this was a fantastic program of work with people that you potentially recognise who have now become our postdoctoral fellows, Ben, Michelle, Gab, Leon, where we co-designed a clinical pathway of care, specifically focusing on the cancer patient, and had very profound impact in terms of both mortality reduction as well as cost effectiveness. And that's an open source paper, so you can hop in and see the process mapping, all the pathways, everything in it. So just going back to this issue around process mapping and why it's so important. At the time, we realised that there were all different observation charts across different areas. There were different screening procedures. There was a knowledge gap in doctors and nurses understanding how to recognise sepsis. But we also knew that there were really difficult issues around communication. Who do we call when there are multiple teams involved? What are the escalation processes? And then a lot of these things happened after hours. And then there were simpler things that were stopping or inhibiting appropriate timely resuscitation. If you don't have anyone on the ward that can cannulate, then your patient cannot get fluid or antimicrobials. There was very poor knowledge of resuscitation practices and fluids being put onto the 999 with a pump rather than a rapid infuser, and then lack of access to antimicrobials, particularly in some areas such as ambulatory care. And we systematically went through this process, through this co-design, including making sure that antimicrobials were available. There were enough rapid infusers, that we trained up nurse cannulators across the hospital, and we were able to very dramatically improve timeliness. And this is a paper pathway, it's bold content is that, but it had everything in there. So you could stand a junior doctor, come onto the ward after hours, a nurse could initiate the conversation. This patient meets sepsis criteria. I'd like to start the sepsis pathway. This is what I've done, and this is what needs to be done. And elements of it supported the nursing, particularly cannulation, doing the blood cultures, venous blood lactates and bloods. And then there were the elements that supported the doctors, which were, did the patient need fluid resuscitation, charting the fluids, and then going through the empiric guidelines to choose the most appropriate antibiotic. And there was a very, very, of all the things I've done, I think quite rapidly adopted, because people would see a change in front of their eyes. And when we look at improvement projects, I often use this structure plus process equals outcome. You need to address structural measures and process measures to improve outcomes. And in our situation, in this pathway, we introduced early warning criteria. We supported a very important, probably the most important element, which is to support nurse initiation. We put it into a clinical pathway format with clearly defined time periods, what needed to be done in that first 60 minutes, what needed to be done in the first 6 hours, when did tests need to be repeated. It also supported better coding, because it became a medical record document, became a very official document, and was able to be picked up and used with empower the nurses. And then the process measures, of course, around blood cultures, lactate, choice of antibiotics, time to antibiotics. And we were able to demonstrate all these things. Very significant reduction in ICU admission, 50% reduction in mortality, reduced length of stay. This was again some work with Michelle, who was one of our Centre's PhD fellows. This is what we call an ISA, incremental cost effectiveness ratio, which shows that the pathway in our situation was both cost effective as well as life saving, so life years gained. And this was a minimum. So in the surgical patients, actually, it was a wide confidence intervals, but there was at least 32,000 saved in the surgical patients. So this is something that we were able to replicate when the same pathway was scaled. The story is a little complex now that we've moved to an electronic medical record, and it's fair to say that it has been a challenge moving into EPIC, and that's because that whole of pathway, you were able to look at the whole pathway and discuss the pathway, manage the patient, is very different in an electronic medical record where individuals are going into the patient. There are different roles. Nevertheless, we have built a best practice alert. We're able to initiate the pathway, and we have a standard approach in terms of the order set. There's a nursing workflow and a medical workflow with some pre-checked requests to make sure that the quality of the workup is appropriate, as well as making sure that there's this terrific empiric guideline for appropriate choice. You can build all these things, but that doesn't mean that people are going to go to it. So there are many implementation challenges that we're painstakingly we're working through, and it is a precinct pathway. So we're working across the Melbourne and the Women's and working together as a team. And then the next thing is actually getting the data out the back end to understand behaviours around it. So this is definitely work in progress, and again, be happy to update you on that. Scaling the pathway, this again was funded, the PEDIMAC WICMIX project was then funded from Better Care Victoria to then scale to Royal Melbourne Whole of Hospital. The cancer wards at the Royal Melbourne had already adopted it very quickly, actually. And to this day, they are probably the best performing group in terms of utilising the sepsis pathway. But we did scale it across the whole of the hospital, again showing very similar impact in terms of mortality reduction in ICU admission. And then there was a scaling collaboration fund which we led out of the Royal Melbourne Hospital to 23 hospitals, and they included both rural and metropolitan, and some sites were Cerner sites and some have no EMR. And again, a project over 12 months, very an intense project, but led to very significant outcomes. So how do we do it? This is what we call a supported collaboration. And I think this model of scaling, what I call scaling collaboration, is definitely something that we can look at for other areas, particularly in cancer care, because we were able to create this wonderful community practice across the regional rural hospitals. And we embedded consumers at every hospital as well as the steering committee level to make sure that they were embedded and involved in the project from the get-go. Each hospital took a whole of hospital approach, and there was sufficient funding to support a project officer and a clinical lead at each service. And I think that's really important, because in some hospitals like Corryong or Warrnambool, it wasn't always easy to find people who had the funded time to be able to do an improvement project. And I think while it's admirable that we have we need to do these improvement projects, there does need to be some dedicated support for particularly people who are coming in for the first time to run one of these projects. And that included a lot of data collection using REDCap's databases and all these things that are very new for some of the staff. Much of it was utilising what we'd done at both PEDIMAC and Royal Melbourne, and we provided them with very detailed toolkits. And again, you can jump onto the Think Sepsis Act site and all that is available to you. But the most gratifying thing is that it was a very quickly adopted program, because it led to this significant empowerment, particularly with the nursing leadership role, and they could drive the pathway. And on the right-hand side was a carer where the pathway was discussed in front of her and her son, and they could feel that it was a very highly coordinated response. And people enjoyed doing this project, and it's a really good model, and I think something that could be replicated for other domains. So just in the implementation phase alone, there was lives saved, intensive care admissions avoided, reduced length of stay, and a 6 times return on investment. And that's even adjusting for age, sepsis severity, etc. It's a very effective program. I wanted to spend a little bit of time before I finish talking about advanced nursing practice in this field. And down the bottom, we have Belinda Lambros, who's an APRA accredited nurse practitioner. And she was an NCIC fellow, as well as half funded through her low risk role. And she has now built up a scope of practice, which I think is really exciting, and we should be scaling to all cancer services. And she has a role where she looks after low risk patients. She oversees the implementation of the sepsis program. at all levels. She does skin prick testing, allergy challenges, has her own clinic, supports the antimicrobial stewardship program, vaccination, supports infection prevention, and does an enormous amount of education. So a shout out to Belinda, but really highlighting that these sorts of programs or these sorts of clinical practice skill sets are ideally suited to scaling in cancer centres around Australia. So this is my last slide, or second last slide really, but it's about where to next. And our team at PaediaMac and the National Centre and all our collaborators across the country have been working in this space for quite some time. But really, and I haven't talked about our vaccination pathways or even allergy program today, but the next step is really to look at that, the digital space. How can we integrate these pathways into our digital health strategy? How can we build on virtual models of care? How can we support regional and remote sites that don't have infectious diseases expertise to make sure that patients with cancer are supported? And these models are, I think, are really, this model is really important for us to take that next step. And my last slide, and thanks to Monica for this picture, is really a photo of some of our team. That's not everybody. We're up on the, I think on the 12th floor, I think, of PaediaMac. So, oh no, that was at a Christmas drinks, wasn't it? So thanks to all this, to many of these collaborators, PhDs, postdocs, and our research staff at PaediaMac who have been supporting this work for many years. So I'll finish there.
Thanks very much, Karin. What a great presentation. So we're just waiting for a few questions to come up, and again, please use your Q&A function and the chat function there. You won't be surprised to know that I might have a couple of questions arising from that. But before the questions, just so the audience knows, every time you hear Professor Thursky speak, you'll learn something new. So I learned the phrase supported collaboration, and that makes sense to me. I also learned the equation S plus P equals not zero, but O, outcome. And I was a bit worried until you said that it was O, and that made sense. Look, a question just around the picnic. So I love the acronyms that you and your team always have. So it worked well in the UK. You did an evaluation here in Australia and it scored poorly. You then said you recalibrated it, and then the UK adopted it. What's recalibration? Are there big changes there, or is this tweaking things? Or
it's really tweaking. There was a different rule actually. The rule that performed best in the Australian population was so-called SPOG rule, which is a Swiss rule. I think it's a terrible name. Apologies for that acronym. And it's a really quite a simple rule. I can potentially pop up a slide showing you, but it's really about particular patient groups, lymphopenia, and you know, 2 or 3 variables to just pick patients who are more likely to be low risk. And the important thing about these prediction rules, they're really to support an approach, because as you know, Andrew, you might have a patient who classifies low risk on a rule, but there are physician preferences to whether or not you want that patient to go home. And so this is really the approach that we, particularly with paediatrics, is really important, that no rule is hard and fast, but it just suggests that the patient's going to be suitable. So recalibration is really a statistical approach to tweak the rule to make sure that it is going to be a rule that functions well enough to be put into a clinical pathway of care. Does that answer your question?
Yeah, no, so that's very helpful. So now I'm a bit worried, right? So maybe you gave the answer in your talk. We read in the literature these tools and these pathways and these scores, and perhaps naively I thought that you just go ahead and apply them. But have you got a sense of what the hit rate for needing tweaking is?
Well, I don't know. I don't know if I'd use the word hit rate, but if we talk about the sepsis 3 criteria, which were published in a big bang article in 2016 in JAMA, and there was a QSOFA score, which was a simplified score to predict patients' risk for increased mortality. There was no external validation of that outside of the internal validation in the big data set. And what happened when it went live in reality is that it missed 50% of patients with severe sepsis. And yet it was widely endorsed. Well, wasn't endorsed by some groups, but it was widely adopted all over the world. Now, this last month, the Surviving Sepsis campaign published their updated guidelines advocating against the use of the QSOFA. And so it's more a word of caution that if you are going to be using a clinical prediction rule, and there must be some even in cancer docs, you need to know what you're measuring and how well it's performing. And I think that's a really important point. And the other area, it is interesting for me, particularly in the sepsis space, that much of the research has been driven in intensive care and ED, and that's all very well, but the implementation of them, how they perform in real life and how they're incorporated into a clinical pathway is really the effort that needs to be done. And so it's one thing publishing a score, it's quite another thing understanding how it's going to be applied in real life practice. So that's my lesson.
Yeah, no, you illustrated that well. So a couple of things in the Q&A. The first is, I think, a comment that's going to be felt shared by many. Professor Thursky is not only a star, but an incredible and caring clinician. You don't have to say anything to that one. Just take that one.
Thank you.
Next is wonderful talk, Karin. Really great effort there. I might have missed this, but has there been any recurrent infection or relapse? If there has, is there any association between the period of relapse and how long the patients are on antibiotic? And then there's some follow-up stuff to that, but if you want to tackle that.
So if we're just looking at the low risk neutropenic fever pathway here, we just put that aside, putting sepsis aside here. We do accept most of the scoring tools have an accepted, I guess, failure rate. So we do expect for example, the MAS score, for example, has about a 5% failure rate. So we know that maybe 5% of patients might redevelop a fever and need to be admitted. But in the years that we've been running the program, it's actually been really very safe. And patients often come in for other reasons. So they might get diarrhea from the antimicrobial, they might develop another complication. They come in for symptom management rather than failed infection management per se. So we actually are very keen to expand out the population that's suitable to be adopted in that program. But again, as I said before, we need to relook at, do we need to tweak the MAS score? Do we need to look at, that was only ever validated on solid tumours and lymphomas. It was never validated in leukemia. And yet we know that there are many patients that we're starting to send home with the hospital home program at the Royal Melbourne, for example. So, we are shifting our programs and we need to be adapting our scoring systems as well. So your last question was, what do you think would be the most important factor to establish consensus and rapid diagnostic of sepsis? Well, there is some movement there. There is a national sepsis plan, and I'm involved in establishing what we call the clinical care standards for sepsis, and they'll be released June next year. And that really is starting to say things like hospitals need to have a sepsis pathway. Hospitals need to have venous blood lactate available. Hospitals need to have appropriate communication with patients around sepsis. And one of the things that our consumers have said to us very strongly is they were often never told that they had sepsis until the very end or the next admission. They didn't know. No one mentioned the word sepsis. Our patients want to be, they want to hear the word. They need to understand what it is and what they need to look out for. So there's an enormous piece of work in that clinical care standard around communication, and also the post-discharge management of patients with sepsis, because we know they can have quite a profound impact on their quality of life for some weeks after, if not months. So the clinical care standard will, like accreditation in a way, will drive all sites to think about it. And then the rapid diagnostics is very challenging. Our team here are collaborating with Mark Pellegrini at the WEHI, and we are going to be looking at, with our latest synergy grant, we're going to be looking at CRISPR-Cas technology, looking at diagnostics for infection pathogens for patients with cancer patients with sepsis. It's really exciting, and it is an area of interest for us for sure, but a very challenging one as well. Consensus, I really hope we can achieve consensus at a national level, but I think it's going to be a tough road.
Easier for you than on something. Editorial comment. I know Belinda Lambros has popped in the chat that with respect to, I guess that's relapses of infection, only one in the last 3 years has required readmission here. So that's pretty outstanding.
Yeah.
Can I ask, I worry a little bit about labels. So you've just emphasised how important it is for a patient to know they've had sepsis and to understand what that is. But not everyone we treat as sepsis has sepsis. And are there some downsides of having a label that's hard to erase or remove? Is that a problem, or is that me just being theoretical?
Well, I think when patients are really unwell, I think, of course, that's exactly right. When you're working them up, that might, in particularly your group of patients, is not always sepsis. And I think from what I've seen, most groups will have that discussion when we need to do blood cultures, et cetera, et cetera. But the feedback from our consumers, particularly in the scaling program, was very strongly that they want to have that discussion. They need to have that discussion, and the carers and the patients need to have that discussion. Our consumer for the National Clinical Care Standards is very strongly the opinion that patients need to have that discussed in ED at the time. And as you say, I think your reservations there probably reflected some of the clinicians, but absolutely at discharge, when the patient's being sent home, the common scenario is that patients can be profoundly impacted by if they've had a significant episode of sepsis, and they need to understand that it takes some time to recover from that. And I think that's, it's hard enough with the cancer care, let alone sepsis on top, particularly because it often delays treatment and everything else. So I think having that discussion is important, but obviously needs to be tailored to the risk and tailored to what's happened to that patient.
Low-risk neutropenia pathway, there are a couple of key things you highlighted, and so I'm just wondering whether what was the key element? You emphasised having a good name. There's no place like home. Without trivialising, that is a good name, but without trivialising, how important is having a catchy name to get uptake? And then the other thing you emphasised was nurse-led. You emphasised that a couple of times. Where do you put those two in the scale of importance?
If you ask me, of all the things that I've ever done in my life as an antimicrobial steward, infectious and cancer, I just think that we need to recognise that the nurses are coordinators of care. They are with the patient, they're at the front line. If they believe and understand the program, they're enormously effective in driving care. And having clinical pathways in particular, something that they can initiate or at least start the discussion with, then I think Belle's online today, of course, and she would absolutely agree. But having said that, it does require education, and we have staff at all different levels of awareness, education. We know already with the sepsis pathway that in EPIC, they are less confident about making that call that they think the patient has suspected on an infection, whereas they didn't before, but with EPIC they do. So we know that the electronic medical record has changed confidence and behaviours about some things. So hence it comes back to my point around the importance of taking a very careful implementation approach, which is actually unique for every organisation. So you can't even plug and, the unfortunate thing is you can't even plug and play these things. And then for some of our sites, we have rotating junior staff every 3 months. You know, you can imagine our lives there. It's very challenging. So, and even some of our most senior ID colleagues are anxious about looking after cancer patients. And I often say to them, well, sepsis in cancer and sepsis in a non-cancer patient is exactly the same. You do exactly the same thing. The fact that they have cancer increases their risk of infection, but the actual resuscitation management is the same. So breaking down the fear, the anxiety for both medical and nursing staff is something that we do spend a lot of time educating on as well.
There's a note in the chat, and very true, that often patients are very sick.
That's right.
ED, and you can't really have that conversation. But you emphasise later in the admission.
Yeah.
Last question before we finish. So you've given us the benefit of all your experience in implementing things in the infectious diseases space in cancer patients. You've seen a lot of cancer patients. Are there anything top of mind that are sort of outside your lane, but they're ripe for implementation or changes in implementation?
Well, I think it's the number one thing is equity. You know, all our patients, no matter where they live, need to have access to the sort of experts you might get in our principal referral hospitals. And so how can we, my area of interest is making sure that these programs are scaled, or if they can't be scaled, that they have access to experts who can help support those local hospitals. So it's really, and I don't think that's unique to infectious diseases. I think it's very relevant for all cancer care, about equity and access.
Okay. Well, look, I'd like everyone to join with me virtually or put your hands together, do something, and thank Professor Karin Thursky very much for a great presentation. I always learn something, and I learned plenty today. I hope you all enjoyed that. Our slide now tells you what's coming up. A couple more great presentations to round out the year. You can see them there. You can also see the QR code so that you can access both the programs going ahead and the live stream that's been recorded. And you can register for upcoming BCCC Alliance events using that QR code. So that brings us to the end of today's Monday Lunch live stream webinar. We've thanked Professor Thursky, and I'd like to thank you, the audience, for tuning in, and thanks to BCCC for putting it on. Thank you.